Okay, so for this one, we're going to talk about prone positioning. So this is the actual process of like putting our patient in the prone position. So the physiological rationale for prone positioning and to prone position our patients is to improve our VQ mismatching, to reduce lung compression, improve secretion drainage with all that edema and fluid buildup in their lungs, just to help remove that and oxygenate better. And then uniform lung inflation. Our indication for proning is moderate to severe ARDS. So patients with a PaO2 or an FiO2 ratio less than or equal to 150 mmHg despise optimal mechanical ventilation. So that means their PEEP is at the highest rate, their FiO2 is greater than 60, and they're just not responding and not oxygenating properly. Or refractory hypoxemia. This is where patients who are put on oxygen therapy, but their SpO2 still remains pretty low within their 60 to 80% range. Early intervention within the first 12 to 24 hours may prevent a ventilator-induced injury. So a lot of facilities like to get a patient with ARDS on a mechanical vent setting within the first 12 to 24 hours just to prevent further damage to their lungs. Other potential indications are certain surgical procedures like spinal surgery, a glute surgery. So the patient has to be on their belly instead of on their bottom. Treating dorsal lung atelectasis and enhancing secretion clearance. Contraindications are unstable spinal fractures. Obviously, they can't be on their back if they have a spinal fracture, so they have to be on their belly. Severe hemodynamic instability, so the patient's heart rate, respiratory rate, pH, like all their hemodynamics are unstable and they can't be moved around. So you first have to get your patient stable enough before you prone them. Elevated intracranial pressure, that's if the patient had some kind of brain injury, head injury that's causing a lot of pressure on their brain and their skull. A recent sternotomy, that is a recent surgery in their chest. So their chest was cracked open, and they are unable to lay on their chest due to, danger of opening the sutures or something going wrong. Large ventral blunt trauma or burns. Large ventral burns. They have a lot of burns on their chest, so they just can't be on their stomach. Unstable pelvic or long bone fractures. Obviously, if their pelvic is unstable, you cannot prone them since they will be laying on their pelvis, on their stomach. So they would have to be on their back to relieve that pelvic pressure. Okay, we'll go to the next one. Prone positioning continued. So preterm considerations for this, airway management. So you have to secure the ET tube with a tape or a tie and ensure the respiratory therapist is available to manage the ventilator tubing and secure the head during the turn. Pressure injury ventilation. It assesses skin integrity on the anterior surface and places protective padding on bony prominences like the forehead, the cheeks, shoulders, iliac crest, and knees, just to prevent pressure sores, infection on those pressure sores. Preparation and equipment, utilize a gel head positioner, chest rolls, hip rolls, extra padding to relieve those pressures on the abdomen and chest. Patient stabilization, ensure deep sedation of neuromuscular blockage to prevent movement during the turn. I mean, you don't want your patient to randomly just start moving when you guys are trying to turn them, because that can be very dangerous for the staff and for the patient for sure. Stop feedings at least 1 hour prior to turning the patient, just for aspiration risks. I mean, they already have ARDS, so you don't want them to aspirate more and cause more damage. Medical lines and devices, check all central lines, urinary catheters, and ECG leads to prevent dislodgement or injury. Ensure your ECG leads are on the back. and not on the front of your patient. Team coordination, conduct a brief with all the team members. Just make sure that everybody knows their role, everybody knows what way the patient is being moved, so everybody does it simultaneously. And then the role for the RT is to secure airway, to make sure that the ET tube is intact and is in place at all times. So the RT will directly hold the ET tube and chin throughout the entire maneuver to prevent extubation. The team coordination, the RT often directs a team of 3 to 5 people to ensure a synchronized turn. Preparation, you will pre-oxygenate your patient at 100 FiO2, suction the airway just to make sure that in the process of moving, there's no secretions that kind of slide down if the ET tube does get moved a little bit and like leaves a little wiggle room. And clamp the tube, the feeding tube, so make sure there's nothing else going in. Ventilator safety, monitor all the response and make sure that all your ventilator tubing will not be disconnected or there's no kinking during the turn. And then post-turn verification, like immediately check your ET depth, your cuff pressure, breath sounds, make sure like you suction everything really good, everything is secure, everything is in place. And nothing was moved. Okay, in this slide, this is a prone checklist. It's a nursing checklist, but it's almost kind of similar to, I'm assuming, what an RT would have. Pressure point areas for like the head and the face, what to apply, like ETT position in the middle of the mouth, not compressing the lips. So they want to make sure that the ET tube is right in the middle so it doesn't kind of push anything on the cheeks or the lips to cause skin breakage. Tracheostomy, so that's not kinked or occluded, NG tubes, all of that. Neck, just to like verify the patient's lower back and neck are hyperextended, nothing's like crumped up or put in a wrong position to where it's uncomfortable and eventually it can become dangerous because it can not allow the lungs to expand. The chest, all their drains, if the patient does have drain tubes or anything of that sort, probably I'm assuming like ECMO, if they have ECMO by their neck or like their groin area, to make sure that none of that is occluded and all those lines are straight and taut. Abdomen, the abdomen has to be free, so like nothing pushing on it. The pelvis, you have to put support cushions or pillows or foams. The side, the arms and stuff in the side, normally for a intubated patient, the patient's arms are tied down. So during this time, and every 2 to 4 hours, the patient's arms are put in like a swimmer's position where the opposite hand is like up almost like above their head and one is like almost hanging lower. And then those are alternated. During that time, also, RT will come in and reassess ET tube placement, make sure everything is normal, all the ventilator settings and alarms are reading just as they should. And then infusion monitoring, that's recommended, like checking x-rays, ECGs, just checking ABGs to making sure that the patient is balancing and coming to a hemodynamic stability, if that is with pH or CO2 retention or, all of that. So that's what that looks like. This is a rotoprone bed. I personally have not seen one in clinicals. I've heard a lot of people have seen a couple of them. And I've also heard from previous RTs that these are a little bit hard on patients just because like of all the cushion and all the pillows. So they do leave a lot more skin breakage and like bruising on a patient. For this one, position techniques and preparation, you turn off all kinds of tube feed an hour prior. You have to make sure you empty the urinary drainage bags and then ensure all lines tubes are secured and have sufficient slack. Applying prone packs, lower leg position first adjusted to avoid pressure on toes, abdominal placed to support the abdomen adjusted for lower or lower for larger panis, chest positioned at the top of the bed, secured but not overly tight initially. Securing the patient, place the patient in the swimmer's position. That position again is like one arm up, one arm down, alternating sides every 2 to 4 hours to prevent pressure injuries. Turning procedures use a hand control to depress the prone position. The bed would only move while the button is held, allowing for immediate stopping if necessary. So it's kind of like a robot, and it will prone and move the patient by itself.